Hello and welcome to the WPS webinar on skilled nursing facility minimum data set, or MDS, PDPM drivers. My name is Mary Sue Gardner and I'm a registered nurse in the Provider Outreach and Education Department. And I'm joined by my fellow nurses on Provider Outreach and Education, Rachel and Jennifer, who will be assisting with the question and answer portion of today's call, as well as helping me monitor the chat. I also have some representatives from our medical review department available should we need their assistance for any questions and answers. So again, today's webinar is focused on the skilled nursing facility services and the payment drivers from the PDPM that affect your skilled nursing facility claims. On your screen, as well as in your slide deck, is our disclaimer. We have a disclaimer that we have to show you at the start of every event that we host, and this disclaimer basically says we prepared this education based on the current Medicare laws, rules, and regulations as they exist, but if those laws, rules, regulations happen to change tomorrow, it's your responsibility as a provider to make sure you're following those changes, because Medicare rules will be the final determination of coverage. Also, CMS prohibits you from recording, either screen recording or taking screenshots of this event. However, we are recording this event for you, and pending the outcome of that recording, it will be on our YouTube page as an encore within the next week. Now, Medicare's full of acronyms, so I may use any and all of these acronyms as we are talking today. If I happen to use an acronym that you do not understand, please just refer back to this page. My objective for today is that you learn about the sections of the MDS that drive the generation of the PDPM codes. And I want to focus on how specific sections and specific items on the MDS affect your Medicare claims. They also can affect payment, and we're going to discuss how these impact medical review when they are looking at your claims. So as we move on, let's talk briefly about what is PDPM. The patient-driven payment model, or PDPM, that's a case mix group classification system for classifying skilled nursing facility patients into a Medicare Part A covered stay and into payment groups under the SNF prospective payment system. It became effective October 1st of 2019, so right before the pandemic. And PDPM replaced the case mix classifications and RUG groups, or resource utilization groups, which was RUG version 4. Under RUG version 4, most patients were classified into a therapy payment group, which used primarily the volume of therapy services provided to that patient as a basis for the payment classification. And this really created an incentive for skilled nursing facility providers to furnish therapy to SNF patients regardless of that patient's unique characteristics or their overall goals or needs of that skilled nursing facility. So what PDPM did was to eliminate this incentive and improve the overall accuracy and appropriateness of SNF payments by actually classifying patients into payment groups based on specific data-driven characteristics, while it simultaneously reduced administrative burden for skilled nursing facility providers. So PDPM classification system is structured to include beneficiary interviews and input into the data that's actually submitted on the MDS. So as we move on, the RAI, the Resident Assessment Instrument, this actually helps nursing home staff to gather that definitive information on your resident strengths and needs and things which must be addressed in an individualized care plan. Interdisciplinary use of an RAI promotes this emphasis on quality of care and quality of life. The MDS is a core set of screening and clinical features, functional status elements, and includes some common definitions and coding categories, which forms the foundation of the comprehensive assessment for all residents of nursing homes that are certified to participate in Medicare or Medicaid. So to put that easily, the MDS 3.0 is the tool to conduct your assessment. So that was just a little background about those items and terminology, because I know we have people on that are new to Medicare and new to skilled nursing facilities. So I wanted to give that little bit of background information. So now we're going to turn our attention to the sections of the MDS that impact your overall Medicare payment. On the screen, and if you're following along with the slide deck, we've provided a link to the Briggs Sample MDS 3.0. And I like to use this sample in training because they've highlighted areas in which there are Medicare indications, which makes it really easy for you to see which areas affect Medicare. I'm going to use the link on the slide and go out and show you their sample. Now, remember, this is a sample and it's marked as such. I'm not promoting it. I have no vested interest in the company. I just like the way it is set up and includes the Medicare indicators. And I figure if I like it, you guys will probably like it too. So as that opens, and I will pull that into view here. On your screen is the sample of that Briggs MDS that I was talking about. And again, you can see that it's marked right here as a sample. So as I go through this sample, I'm also going to include the information that is included on some of the upcoming slides in your slide deck, especially when it comes to sections G, G, I, and O. I am actually going to be hosting webinars later in April that are specific to sections G, G, I, and O. So watch for those 3 webinars to be posted in the next week or so. And we're also going to be hosting an event on skilled nursing facility certification and recertifications, because we're finding we're having a lot of issues with improper certifications and recertifications. So again, watch for those coming out in the next week or so from our live events page. All right, so starting on the first page of the sample, you're going to notice at the top of the screen, there's some indicators right here in green, noted, up here in the top left corner. The green money bag, which is this first one, which doesn't want to highlight for me, but that's okay, indicates that section affects PDPM payment. The general green and the green hexagon indicate SNF quality reporting measures. So as we stay here in section A, there's a green indicator and money bags down here in A0310. That's because for Medicare, we need you to mark what type of assessment you're completing, because again, that affects your payment. The identification information is used by medical review to start their review. They need to verify the beneficiary. They need to find the MDS assessment that you stated that you completed, and that's locked into the MDS repository, and verify that information exists in the documentation. So as we scroll down, and we'll come to another section under A. I'm trying to scroll slowly so not to affect your eyes. Down here, we get into section A 2300, and you can see that it starts asking information about the patient's hospital stay. That's important to know because if the patient did not have a qualifying hospital stay, then Medicare is not going to pay for a Part A skilled nursing facility stay. So we have to verify that that patient has had that qualifying hospital stay. We did have a lot of review issues with this during the public health emergency and the inappropriate use of the DR condition code. We had lots of claims that we received in which the DR condition code was appended to the claim in order to bypass the need for the 3-day qualifying stay. But there was not any documentation or proof of why the patient could not stay in the hospital for 3 midnights. So, like no availability in the hospitals, lacking staff, etc. In order to use that condition code during the public health emergency, there must have also been proof as to why that stay couldn't happen. And in most cases, the DR was used inappropriately, and the hospital stay was just bypassed without any indication of why. And I bring this up now, even though we're no longer in the public health emergency, because the use of the DR condition code could go back into effect if there is some sort of state emergency or a state emergency declared, like a flood or a tornado, maybe there's another pandemic, etc. So I wanted to, give a little stopping point on that and make sure that you know about it. Okay, so scrolling down into section B, which is the hearing, speech, and vision, you'll see that there are indicators in this section as well that may adjust your payment amount. So things like comatose, making themselves understood. Again, upon medical review, we must look at the documentation to make sure what you reported on the MDS in this area matches your actual documentation. Okay, oops, sorry about that. All right, and again, down here, you will see those money bags that cover that. We move into section C, cognitive patterns, and this is where you complete your BIMS assessment. We're going to look at this for accuracy that's reflected in your documentation. You can complete the BIMS here and report the scoring here, and that's fine. And we'll verify that through your documentation as well to look for things like the staff is noting any kind of memory problems, recall issues, orientation that exists that reflect the score that you gave in the BIMS here. We're also going to look for things like speech-language pathology involvement, if that is necessary, and maybe there's nursing staff or carryover with cueing, such as like memory books or indicators on the wall, etc., for that patient. Again, lots of indicators here that are marked with money. When we do reviews, and just so you know, as we proceed on with this, our staff, I shouldn't say we because I am not in medical review, but our medical review staff basically recreates your MDS based on your documentation. So we will extract the MDS that you have submitted into the repository and go back and make sure everything is correct. And we're going to verify your documentation and make sure that if you captured it on your MDS, it is verifiable within your documentation. If it doesn't exist in the documentation, then it can't exist on the MDS by itself, and expect that we're going to give you that payment category that it came out to give you if we can't see that that was done. So, all right. As I scroll on, the next section is section D, and section D continues with mood. So this section also contains the PHQ-9 as well. So as with the BIMS, the PHQ-9 can be completed here and doesn't have to be recompleted again in additional documentation. However, findings should be indicated in the documentation to support the scores that you're reporting in your MDS, okay? So we need to see those things. If there are indicators of depression, we need to see what interventions are being done related to that. Is there need for medication? Is there need for therapy, et cetera, based on how they scored on the PHQ-9? So again, carry over in your documentation is of utmost importance to make sure you are addressing these items correctly. All right. As we scroll down into section E, we're going to get into behavior. Section E contains additional indicators that could affect your HIPS code and payment amount. These include things like hallucinations, delusions, the presence and frequency of those symptoms. As with the other sections thus far, if it is indicated in this section, we are going to be looking in your documentation to support this. So if you mark any of these potential indicators, we need to see that that's also been addressed in your documentation. Let's see. Oh, here's one thing I wrote down some notes. This was from you know, I know I've said a lot. We need to see it in your documentation. We need to see it in your documentation. This came from a tagline that one provider had that I was communicating with via email, and I thought it very interesting enough that I wrote it down and stuck it to my computer. And their tagline said, remember, if you considered it, suspected it, reviewed it, were concerned about it, thought about it, or monitored it, then document it. Because we go back to that old mantra, if it's not documented, it's not done. All right, so section GG. Section GG is a big one. Money bags in section GG as we scroll through. So there is a lot of indication on payment in this area. Section GG now includes the old section G. So just so you know that, make sure you are using the most current MDS. Your MDS should now not include a section G because that was updated several months ago, and everything is now just in section GG, which is your functional abilities and goals category. So the issues that are being seen upon review are in the drivers of this section. Significantly and specifically play into the info that must be entered and documented within the first 3 days of the skilled nursing facility admission. So as we scroll down and we start reading some of these sections more completely, pay attention to your assessment period. Section GG is specifically the first 3 days of the stay. All right, so down here in the self-care part, again, you see money bags in these self-care areas listed down here, which means these areas drive payment indicators, which also means we're going to pay very close attention upon medical review to ensure how you mark it on the MDS is reflected in the documentation. So this means we're going to specifically be focusing on self-care assessment and the resident's level of performance with the associated code that's documented on admission to the SNF. So in this column 1, which is the admission performance, and as we scroll down, you can see it continues on to the next page. All right. So things up here, eating, oral hygiene, and toileting, and then that continues down here with the patient's ability to go from sit to lying, lying to sitting, sit to stand, chair to bed to chair transfer, and toileting transfer. So those are the specific items that we're going to be focusing on, which means we're going to look very heavily to the nursing documentation, to any therapy evaluations, any therapy care that has been provided to see how the patient is doing with these items upon admission. And to make sure that the documentation matches the amount of help you say this patient needs in these specific areas. So just for an example, if the MDS is marked that a patient is completely dependent with sit to lying, but the nursing records indicate that they're supervised only or supervision only, we may end up having to change that MDS. Sometimes this may not affect your HIPS code, but oftentimes it does. Especially when we're talking about section GG. So again, we're going to look for information to support the level of services. And we're going to look and make sure that it is being documented consistently. Now, we do understand that sometimes the way therapy assesses an individual or sees a patient's function can be a little bit different than sometimes how nursing sees a patient function. Or sometimes a patient may do really, really good in the morning, but and do great with therapy and be more independent. But when they're with nursing later in the evening and they're tired, they may be more dependent on staff for those cares. So just make sure that you are talking, your MDS coordinator is talking with everyone when they are making the decision on how much dependency that these residents truly have, and that you're marking it adequately. All right. So again, GG goes on for a few pages here. And again, there are green marks. So we know those are things that could potentially affect your Medicare and Medicaid claims. And as I scroll down, we're going to go to the next section, which is section H. Again, and don't worry about GG so much right now because we are going to host a whole webinar just on that specific section. Pull that out of the way, so sorry. All right, So as we move on, and let's talk about Section H. Section H is on bowel and bladder and includes things like ostomy, intermittent catheterization, toileting programs, etc. So in this section, we must ensure that the documentation, again, reflects what's coded here. These, again, could affect your HIPS code. So we really look to your documentation for this information. And if it doesn't exist, we are going to remove it from your MDS when basically we're recreating it. All right, Section I. Section I is another big one that also drives a lot of Medicare payment. So again, posting a separate webinar just on Section I next month, but I want to hit some of the most important features because there's so many issues with correct reporting in this section. So this is the active diagnosis section. First, you must choose a primary medical category for the patient up here in Section I0020. This is based on the reason the patient needs to be at the SNF. If you refer back to the RAI manual and how to correctly capture the diagnoses in this area of the MDS, you only include active diagnoses that have been diagnosed in the last 60 days. The items in this section are intended to code diseases that have a direct relationship to the resident's current functional status, as well as their cognitive status, their mood or behavior status, any necessary medical treatments, any necessary nursing monitoring, or even potential risk of death. So one of the important functions of the MDS assessment is to generate an updated, accurate picture of the resident's current health status. That's why this section focuses on those diagnoses that are active. This should not include past medical history diagnoses and things that are not a treatment indicator for the skilled nursing facility. So for sections I0100, which is the sections that are currently on the screen, you're going to look and see if any of those noted diagnoses of one of the following is in the 7-day look-back period. Ulcerative colitis, septicemia, wound infections, etc. All these things that are highlighted with the green and the money bags. So again, diagnoses identified within the last 60 days and treated in the SNF and driving patient care and the plan of care, and is also active within the last 7 days. So I do encourage you to refer back to the RAI manual where it defines active diagnoses, and it's stated in the RAI manual that active diagnoses is physician documented diagnoses in the last 60 days that have a direct relationship to the patient or resident's current functional status, cognitive status, mood or behavior, medical treatment, nursing monitoring, or risk of death during the last 7-day look-back period. Again, we're going to host an entire webinar just dedicated to Section I and active diagnoses next month. All right, so as we scroll on, and we're going to hit Section J. And Section J doesn't have as much indicators, but we still want to talk about those things that are an indicator. So things in Section J that are an indicator and could affect your payment and drive your payment include things like shortness of breath, if there's documented fever or documented episodes of vomiting within the 7-day look-back period. So it is crucial that your MDS coordinator takes these things into consideration and sets your ARD date accurately, so you can capture if any of these things happened in the hospital in that look back period of time. So Section J also includes surgery that if the surgery prompted SNF care in the last 100 days prior to the SNF admission. I'm going to scroll down here a little bit more. We'll get to prior surgeries. And J 2100 and on include a list of surgeries to choose from if you marked yes up here. So if you marked yes in recent surgery that required active or requiring active skilled care, if you marked yes there, there is a list of surgeries that you can choose from down here. Again, if we can't find it in the documentation, it's going to be removed from your MDS upon review. All right, Section K is on swallowing and nutritional status. So some of the big drivers here are if the patient has any of the following, again noted in the 7-day look-back period, like swallowing disorders, documented loss of solid foods from the mouth when they're eating, holding food in the mouth, etc. All these that are in K0100. Again, they need to be reflected in the documentation as well. Other indicators in this section include things like weight loss and the percentage of weight loss for this patient. As we scroll down, you can see big drivers also are parental or IV feeding, feeding tubes, mechanically altered diets, etc. Like with swallowing disorder, items, that were listed in K100. I'm losing my mind here for a second. Regarding feeding, I'm sorry. You also make sure you need to note if those things had already occurred on admission while the patient was a resident of the skilled nursing facility or while they were not a resident of the skilled nursing facility. We're going to check your nutritional records. We're going to check any speech language pathology records, any nursing notes, etc., to help verify this information. And again, the proportion of tube feeding that this patient may be getting if they are on parenteral or enteral feedings, and the average fluid intake per day that is being done. So while they're a resident and during the entire 7 days. So again, I can't stress enough, pay attention to those indicators and make sure it's captured in your documentation, because we are going to go looking for it. If it's marked here in green, we have to know it exists. Section M includes information on skin conditions. So things that drive this category for Medicare include things like your pressure ulcers or other types of ulcers, including the staging of those ulcers. So remember, if a pressure ulcer is surgically closed with a flap or a graft, it should be coded on the MDS as a surgical wound and not as a pressure ulcer. If the flap or graft fails, you're going to continue to code it on your MDS as a surgical wound until it's healed. Other components of skin care that we're going to review include the treatment of other skin conditions like pressure, and the way you're treating those, like pressure reducing devices, turning, repositioning schedules, wound care, etc. And I think that's all down here. Yeah. So you can see there is not a lot of money bags in this section, but if you are coding that you are treating surgical wounds or ulcers that affect your overall payment, then we have an expectation of you as a facility to also document how you are working to eliminate those wounds, to eliminate that risk of infection, etc. So just because it may not drive your money necessarily, you know, in the way of higher paying HIPS code, it does affect the way that we look at your documentation because we want to make sure you are treating that patient appropriately. All right, so as we move on to Section N, Section N is all about insulin. So if your patients require insulin, things that are going to drive payment are the number of days injections were received in the seven-day look back or since admission, and changes to insulin orders during that 7-day look back. Does that information match what's reported in the MDS? So does your physician documentation of orders and your administration records match what you captured here? If it's not, we're going to change that when we do the review. All right, and then the last big section, and again, this is the last section that we're going to host a whole separate webinar on, and we'll talk about more of this information in that webinar, is Section O. And Section O comes down to your special treatments and procedures and those programs. As you know, and as you can see here in the sample form, there are a lot of things that drive payment that are included in Section O. Again, it's important that you pay attention to the look back information in each of these sections and that you're marking things correctly on the MDS, because it wants you to capture information about, did this occur on admission? Did this occur while the patient was a resident? It asks you about discharge as well, and depending on, you know, if you're using this as only one assessment or if you've had changes, will depend on, you know, how this accurately gets marked. So again, continuing on with Section O and some of the things that specifically drive payment are these things listed here, again, in the green. So we start with things like cancer treatments, radiation, respiratory. Respiratory is a big one. Suctioning, trach care, IV medications, dialysis, and isolation. Isolation's a big one that we often find issues with as well upon review. Very often we find that it's marked that the patient's in isolation or quarantine for an active infection, but the documentation never lists any type of isolation, any type of isolation precautions that are being taken, if the isolation was lifted, when the isolation was lifted. Often we see in the documentation that the MDS, you know, again, is marked. However, the documentation shows the patients eating in the dining room, sleeping in a shared bedroom that's not with another person isolated for the same issue. There's no documentation of additional precautions being taken, and no indication that the isolation was ever listed. And we're not receiving look back information to support that either. So if the patient was on some sort of isolation for an infectious disease that testing negative is necessary for, make sure that those negative tests results are included in your documentation when we go to review. Or if there's a recommended period of time that that person remains quarantined or in isolation, your documentation should support that that patient has met that period of time before being released back out into the general public of your patients and residents. So the other thing in Section O, respiratory treatments and therapy and dialysis are also included in Section O, and I think I already scrolled right by those, but yeah, I did scroll right by them, but that's okay. Remember, for respiratory therapy, we're going to need to see the number of days and minutes of therapy for that respiratory treatment, because it needs to be at least 15 minutes a day in the last 7 days. Section O also goes on to include information about PT, OT, and SLP services. And this includes things like a valid plan of care, diagnoses, treatment diagnoses, daily treatments administered. Those are all things that we're going to look for in your documentation if you are marking that the person's having those. Now, again, you see these aren't money bag drivers, but they are a huge component of skilled nursing facility services. So if you are marking that the patient is receiving those services, we're definitely going to be looking in your documentation for any PT, OT, or SLP notes, whatever you have marked the patient is receiving. We're going to make sure that there's an initial evaluation. We're going to make sure there's a plan of care. We're going to make sure that they're receiving services that are noted under the plan of care. We're going to look to your physician certification and make sure that the physician is certifying the plan of care. But again, don't fret, because we will be going over Section O all by itself and some of those drivers in Section O next month. All right. So that, again, here are those restorative nursing program. That's kind of the last part. If they're in a restorative nursing program, we're going to expect to see that documentation in your overall documentation as well. So this time I'm going to go back to the slide deck. And I do have some slides in your slide deck as I go through those. Again, that's focus on those main areas of Section G, Section I, and Section O that we really pay attention to. But again, those will all be discussed on their own at a separate time. So that brings us to the recap. We covered a lot of information today, a lot of information. So my objective for today was that you, as skilled nursing facility providers, were able to learn about those sections of the MDS that really drive the generation of your PDPM codes. Those that really affect your Medicare payment, but the review efforts by the medical review teams. So we accomplished this today by reviewing and highlighting those sections that were marked in green on this sample that I showed you that impact Medicare claims and payment. And we really talked about how these sections specifically were impacted by the medical review itself, because every skilled nursing facility in the entire United States is subject to a 5-claim medical review based on CMS indications to all of us Medicare administrative contractors. So it's just a way to make sure, since PDPM went into effect right before we went into a pandemic and things were a bit crazy, we all know CMS wanted us as your Medicare administrative contractors to go back and check in on the skilled nursing facilities, do a small little sample of claim reviews, and make sure that the facilities are using the MDS 3.0 and the PDPM codes that they're generating are clear and accurate, and their documentation is matching that. So at this time, that takes us to the question and answer portion time of the call. I am looking to the chat, and I don't see anything in the chat, but I'm going to verify with Jennifer if any questions have come in that I have not gotten to.
We haven't received any questions as of yet.
Perfect. Thank you for checking, Jennifer. And I do see, looking over, there is a question. Do critical access hospitals follow PDPM and paid in this way? So if your patient is a swing bed patient of a critical access hospital, no, you are not paid via the PDPM. If you are in a swing bed of a PPS hospital, then yes, you follow and are paid in this manner. Critical access hospital swing beds, I think, have some different assessments to complete as well. I don't have that information in front of me, but you are paid in a different manner. So not via the PDPM. And so I think that was the only question. All right, perfect. All right, so on behalf of myself and Rachel and Jennifer, as well as all of Provider Outreach and Education and Medical Review, we want to thank you for your participation in today's event.